Thank you, sir. Now we have had a general overview of different kinds of procedures that you can do for your refractive patient. But there are going to be certain situations in which all these options that we have just discussed as standardized options are not going to suffice and not being enough for giving rise to the best possible outcome for your patient, and that is when the role of customization comes in. What I'm going to talk to you about is going to be mostly about the optical customization of the treatment that we can plan for our refractive surgical patients, the selection criteria for the same, and how to plan the procedures and how to go about it. Basically, I'm going to deal with three techniques, which is wavefront optimized, wavefront guided, and topo-guided refractive treatments. I don't have any relevant financial disclosures to make. However, I have received a grant for the study from Alcon Inc. for the topo-guided treatment with cross-linking combination when I was doing my fellowship in the University of Crete. As we have seen, this is the first ever laser procedure in the world done by Professor Ioannis Palikaris. In those times, in 1990s, it blew the world away. Basically, for the first time, it completely revolutionized the laser refractive surgery, giving rise to a great amount of wow effect. So the refractive procedure, what it showed was it had a great efficacy of treating variety of refractive errors, had high predictability, amazingly fast visual recovery as compared to PRK in those times, and gave rise to wow effect. If you look at the recent ACRS survey, more than 97 to 98% patients demonstrate great amount of satisfaction after doing this treatment. However, when we look at the old techniques which were done, especially with the older generations of examer laser, there was a striking drawback. And the striking drawback was the lasers in those times were actually inducing a lot of spherical aberrations. Why that used to happen? As we understand the excimer laser, when it is actually being applied onto the cornea, into its optical zone, towards the periphery, what happens, the elliptical pulses which are coming, they actually lose a bit of its efficacy. So what happens because of that is there is going to be a minor amount of decrease in treatment towards the periphery, which leaves an oblate cornea. So basically, when we have begun up with a prolate cornea and we are not able to maintain the sphericity of the cornea in this regard, and that leads to a lot of spherical aberration inductions. So these induced spherical aberrations in those times give rise to a lot of optical phenomena for our patients, including glare, halos, shadows, nighttime poor vision, and which used to be not a very uncommon complaint in those times. So beyond the standard LASIK treatment, recently now you have certain possible evolutions in which you can tackle all these situations very well. And the first question is, can we reduce the inductions of aberrations that we used to see with the standard lasers? The second question is, can we treat if there are already pre-existing higher order aberrations? And the third one is, how can we help patients who are now coming with topographic abnormalities after the refractive procedures, such as small optical zone, eccentric ablations, as well as keratoconus? So what we understand now is customization is definitely necessary, and the first part of this customization was a minimal tweak in the excimer laser, which came in the form of wavefront optimized treatment. So what exactly is the difference between the standard treatment and the wavefront optimized treatment? As we can see in the standard treatment, because we are losing the pulses in the periphery and its efficacy, you are actually creating an oblate cornea, which gives rise to a lot of induction of spherical aberrations. As against that, in the wavefront optimized treatment, the lasers are now optimized to produce more pulses in the periphery so as to pre-compensate for the induction of spherical aberrations and possibly maintaining the sphericity of the cornea, and thus reducing the possibility of the optical phenomena post-operatively. The second thing which is done with the wavefront optimized treatment is because of the sphericity maintenance, you get a fairly large optical zone as compared to the standard treatment, in which the transition zone actually is a substantial component of the optical zone itself. There has been this FDA trial which has looked at wavefront guided treatment versus the wavefront optimized treatment in the set of patients. Basically what they have seen is that whenever the wavefront pre-operatively is not having significant higher aberrations, which was less than 0.3 RMS value, the wavefront optimized and the wavefront guided treatment actually gave rise to the same quality of vision. As against whenever the patients actually had a significant higher order aberrations pre-operatively, the wavefront optimized were not able to give rise to a good quality of outcome, and the wavefront guided were much better. And that's where is the role of treating pre-existing significant and measurable aberrations in the role of wavefront guided LASIK. As we all understand, in the traditional conventional excimer laser treatments, it corrects only the lower order aberrations, which are the spherical and cylindrical refractive errors. In comparison, the wavefront guided treatment takes into account the measured higher order aberrations as well, in the form of spherical aberrations, coma, trefoil, quadrifoil, and henceforth. So what exactly are these aberrations? These aberrations are basically any deviation from the ideal wavefront are aberrations, and for every individual, the wavefront is going to be like a fingerprint. So it's going to be very, very unique for that person. So whenever you have this aberrations which are analyzed with the help of a wavefront analyzer, as we will see in this small animation, the wave light which is actually reflected back from the retina gets reflected from the lens, the vitreous, the cornea, and the tear film as well. So there is going to be a sensor which measures the irregularity in this wavefront pattern of the light as it emerges from the eye and compares it with an ideal wavefront. This is a unique image of the wavefront that you can see, which is then fed onto the excimer laser. And this excimer laser, along with removing the spherical and cylindrical errors, which are lower order aberrations, are also going to correct the higher order aberrations in this regard. So, should we do the wavefront guided treatment for all our patients? Absolutely not. The wavefront guided treatment should be done for patients who have significant higher order aberrations, more than 0.3 microns in RMS, for 6 mm of optical zone, when the wavefront is actually reproducible and measurable. The night vision and the contrast sensitivity actually, if the patient is already facing those problems in terms of its optical visual quality, and certainly sometimes in retreatments after the previous refractive errors. However, the wavefront measurement itself can have many issues because it is getting affected because of factors such as tear film, pupillary size, accommodations, which makes it very dynamic process. And more importantly, in highly aberrated eyes, it may not be able to get a measurable and reproducible wavefront, such as in small optical zone, eccentric ablations, keratoconus, and post-peak astigmatic patients. And that's when is the role of topographic guided treatments, which are primarily indicated in such topographic abnormalities, as well as now they have been FDA approved for primary eyes which have a positive angle kappa, especially in hyperopic patients. So in just, can I take one more minute please? Yes. So basically, as we see, the treatment which is with the topographic guided treatment involves three components. One is the measurement of the topography, which is then fed onto the software, which is the TCAD, and then ultimately everything is actually put on the EX500 excimer laser, which is the excimer laser that we are using right now. There is going to be about 8 to 12 different scans that you have to take and look at the quality. The best quality scans are then fed onto the TCAD software, which is going to actually calculate by subtracting your own scan from the best fitting sphere, and your own unique ablation pattern is then created, like in wavefront guided treatments. After getting this treatment pattern, actually you have to compensate for the C4, C12 compensation so that you don't induce a lot of spherical aberrations. The refraction is modified at the end, and that is how you get the topographic guided treatment. As we can see in this small example, this is the post-RK eye, which has very small optical zone, which is then enlarged with the help of a topographic guided treatment. Similarly, this is the eye with a post-LASIK small optical zone, which is enlarged with the topographic guided treatment. Post-peak astigmatism, which has been regularized substantially, improving the best corrected visual acuity. And now most recently, the topographic guided treatment has been combined with the collagen cross-linkage so as to improve the quality of vision in the patients of keratoconus, along with stabilizing keratoconus itself. So what is the decision tree? Basically, if you don't have any visual optical phenomena preoperatively, the wavefront is very good, the topography is very regular. More than 95% of the patients today should be good for wavefront optimized treatments, which is an easy and highly predictable way of treating refractive errors today. If the patient has reproducible and measurable significant wavefront error, then definitely the wavefront guided treatment is the way to go. And in patients who require topographic guided treatments, they should have the topographical errors as well. Thank you so much for your kind attention.